Continuous labor support and cesarean section rates. The U.S. cesarean section rate is at an all-time high of 32.2% in 2014 and climbing steadily since 1997. The existing research reflects a positive correlation between continuous labor support and reduced cesarean section rates in low-risk deliveries. Our objective is to evaluate the effectiveness of intrapartum nurses as providers of continuous labor support. The theoretical framework used for this project is the Iowa model of evidence-based practice to promote quality care. The Iowa model fits this study as it describes the impact of new knowledge on the implementation of clinical practice improvement. It also emphasizes consideration of the whole medical system, comprised of provider, patient, nurse, and hospital. The steps for the Iowa model are as follows. Identify a priority problem-focused trigger that will initiate the change. Review and critique relevant literature. Identify research evidence supporting change in clinical practice. Implement the change in practice, and monitor the outcomes. Here's an algorithm for the Iowa model. Using the Iowa model of practice change, we identified priority triggers to action that should be a priority for our organization. The priority problem-focused trigger for this study is the internal and external benchmark of C-section rates. In 2014, the nationwide C-section rate was 32.2% and 33.8% for our hospital specifically. Knowledge-focused triggers include recent recommendations by national and international organizations. These organizations have published various statements to reduce the number of primary C-sections, down to at least 23.9%. They urge hospitals and providers to take measures to decrease primary C-section rates, including implementation of continuous supportive care. Furthermore, Cover California's new policy states that beginning in 2017, it will no longer pay for primary cesarean sections in low-risk pregnancies in hospitals with C-section rates higher than 23.9%. Finally, the Association for Women's Health and Obstetric and Neonatal Nursing states that labor support is the most fundamental role of the intrapartum nurse. Other triggers that we identified include the patient's level of satisfaction and expectations for support provided during the intrapartum period. Women reported emotional support as the most helpful behavior of intrapartum nurses during the labor and birth processes. Other triggers include, but are not limited to those listed here. Cesarean sections can be life-saving in many situations in which mother and baby are at risk of morbidity or mortality. However, the cesarean section rates currently experienced by U.S. hospitals do not reflect the acuity of the patient population. Cesareans that are not medically indicated are often termed unnecessary cesareans. C-sections are costly. The costs continue to rise each year, averaging nationwide between approximately $17,000 and $24,000 in 2011. Cesareans are also more expensive than vaginal deliveries by approximately $5,000. Cesareans can result in a myriad of maternal and fetal complications. Maternal complications include infection, hemorrhage, bladder injury, and uterine rupture. They require a much longer hospital stay, approximately 2 to 3 nights, and can require up to 6 weeks of recovery time for the mother. Cesareans can result in negative implications for baby as well. Respiratory problems, incomplete emptying from lungs and stomach as a result of not being compressed through the birth canal during vaginal delivery, and missing out on exposure to the beneficial bacteria found in the mother's vagina are some of these complications. Additionally, every culture through time has incorporated the support of women by another, providing continuous labor support. The PICO question for this study is, in laboring women with low risk, nulliparous term vertex singleton pregnancies, does continuous labor support by a nurse decrease likelihood of cesarean section compared to laboring women who do not receive continuous labor support by a nurse? Our population is laboring women with low risk, nulliparous term singleton vertex pregnancies. Exclusion criteria include non-NTSV pregnancies such as preterm birth, multifetal pregnancies, breech pregnancies and births, multiparity, and TOLAC. Additionally, high-risk complications and high-risk conditions as outlined here are excluded from our study. Our intervention is intrapartum nurses providing continuous labor support, CLS, consisting of physical, emotional, advocacy, and informational support, as compared to usual intrapartum nursing care. Our outcomes primarily are decreased cesarean section rate, and we will also evaluate secondary outcomes of patient satisfaction. The goal of our literature search, review, and critique is to identify, evaluate, and synthesize current research and evidence to address our PICO question, uncover inconsistencies and consistencies, and determine whether any research findings should be applied to clinical practice. We focused our search using our PICO question. The research question was then applied to find what evidence was available. We used databases such as PubMed, CINAHL, Cochrane, and Google Scholar to apply the search terms as follows. We used several inclusion criteria to conduct our literature search, review, and critique. These specifically included the research design. We included RCTs, systematic reviews, secondary analysis of randomized control studies, and meta-analyses. All information was peer-reviewed and written in English, and the inclusion and exclusion for our population was applied. Additionally, research focused on the outcomes for the patient, such as cesarean sections versus vaginal deliveries with support systems as the main topic, were included in our review. The results of a Cochrane review have been widely disseminated in practice guidelines in the U.S. The publication provides evidence-based recommendations for continuous caregiver support for all women during labor, resulting in the reduction of C-section rates. In the studies analyzed by the review, continuous labor support was provided by a variety of women and men. Only a handful of studies have provided evidence where the intrapartum nurse was the provider of CLS. One of these studies is inconsistent with findings from the Cochrane review and demonstrates no difference in C-section rates among women who received CLS and women who received usual care. The grading scheme used to grade the evidence was the American Association of Critical Care Nurses Levels of Evidence. This grading scheme rates the level of evidence according to the design of the research study, as shown above. Each piece of literature was given a grade based on the criteria from the guidelines. Any articles which were labeled as D, E, or M were not included in our research review. Continuous support for women during childbirth was a meta-analysis of 22 trials involving 15,288 women, and our leading piece of evidence in the literature review. It is a Cochrane review. According to the AACN grading scheme, it is Level A evidence. The purpose of the review was to assess the effects of continuous one-on-one intrapartum support compared to usual care. Results demonstrated that women allocated to CLS were more likely to have spontaneous vaginal birth. Historically, across many cultures, women have been attended and supported by other women during labor and birth. However, as the birth environment transitioned from the home to the hospital in the mid-1900s, continuous labor support has become the exception rather than the routine. Evidence from the literature indicates that continuous support during labor has clinically meaningful benefits for women and infants and no known harm. Therefore, all women should have continuous one-on-one labor support through labor and birth. Continuous labor support should be provided by the intrapartum nurse as to improve birth outcomes and lower C-section rates. One-on-one nurses should remain with the patient except for 30-minute lunch breaks and up to 10 minutes during each 4-hour period for breaks. In the case of labors lasting longer than 10 hours, the nurse can either remain with the woman or call in another supportive nurse to replace her. The central component of continuous labor support is continuous bedside presence during labor and delivery, with an emphasis on social support over medical interventions. Labor support, as defined by Hodnett in their 2013 Cochrane Review, is very similar to the common definitions of social support. Integration of Reva-Rubin's social support theory and Hodnett's definition of CLS provides the foundation for intrapartum nursing care and continuous labor support. One-on-one continuous labor support consists of presence of a nurse during labor and birth who provided emotional support, physical support, instruction and information, and advocacy. Emotional support measures include encouragement, reassurance and praise, caring attitude, presence, therapeutic humor, refocusing, distraction, and coping techniques. Physical support includes therapeutic touch, effleurage, massage, hydrotherapy, promoting changes in position, aromatherapy, applying cold or warm compresses, and promoting ambulation. Elements of continuous labor support for informational and advocacy support behaviors are provided here. Informational and instructional support by the nurse during labor and birth allows patients to participate in the decision-making process. This fosters empowerment and a positive birth experience. Through advocacy, the nurse may be the voice for a vulnerable woman and empower her to give birth with dignity. Some of these include instruction for breathing, relaxation, pushing, and partner care, information about routines and procedures, and patient care, advocacy, which means showing respect, acknowledging mother's expectations for labor and birth, ensuring security and conflict resolution. Nurse leadership roles, including nurse managers and charge nurses, will direct the implementation of the continuous supportive care intervention. During a 40-hour initial training period and quarterly refresher workshops, labor and delivery nurses will perform a critical review of the existing scientific literature concerning the effects of continuous supportive care in labor. With the help of a doula and midwife, departmental nurse leaders will train and educate the nursing staff in the role of providing one-on-one continuous labor support. The nursing staff must perform a return demonstration of all techniques and provide rationale of use in order to pass the training course. All labor and delivery nurses must pass the training course prior to providing care on the unit. Once training is complete, the continuous supportive care intervention will be implemented on the L&D unit. Nurse leadership will continue to monitor the performance of supportive care techniques and ensure that the evidence-based practice guidelines are implemented correctly. All nurses will receive a bi-monthly evaluation and critique of their delivery of continuous supportive care. Here's an overview of the 40-hour training curriculum as shown above. Curriculum may be altered depending on the knowledge and ability of the participants. The objective of our evaluation plan is to evaluate the effectiveness of the implementation of the continuous supportive care intervention in reducing primary C-section rates. Using consistent data collection and statistical analyses, we want to determine whether a difference in our outcomes of interest exists before and after a practice change. The primary outcome for our study is to measure cesarean section rate. The secondary outcomes for our study include women's perception of continuous labor support, and finally, a process-related outcome which will evaluate nurses' perception of continuous labor support. Demographic data will also be collected. The statistical technique we'll use for our study is analysis of variance. ANOVA is used to determine whether a statistically significant difference exists between more than two groups. Specifically, we wish to evaluate whether the implementation of our intervention results in a change in cesarean section rates, nurses' knowledge and perception of CLS, and mother's perception of CLS. The F-test statistic will be used to identify differences between and within groups for outcomes of interest. The F-test is similar to the T-test but used for ANOVA, and it's used to determine whether statistical difference in group means exists between more than two groups. Descriptive statistics will be evaluated for measures of central tendency for the demographic data. An overview of our evaluation design is provided here. Historical data will be collected, the intervention will be implemented, and post-intervention data will be collected. A quasi-experimental repeated measures design was selected to evaluate the effectiveness of our EBP intervention, as it's an effective design to measure change. Our primary outcome of C-section rates will be measured for a total of 2 years at monthly intervals. 1 year of historical C-section rates will be collected prior to intervention. We will then collect data on C-section rates monthly for a year following our intervention. To measure our secondary outcomes, we'll collect baseline data on mothers and nurses for 1 month prior to implementation of the intervention. We'll then collect data from the nurse-patient dyads from a year every month after the implementation of our intervention. The Bryanton adaptation of the Nursing Support and Labor Questionnaire uses a Likert scale to assess women's perception of various labor support behaviors provided by nurses and is divided into 3 categories: emotional, informational, and tangible support. Women can mark whether the behavior was 1, not helpful, or 5, very helpful. They can also indicate whether the behavior was not performed. Here's an example of the tool. Reliability and validity for the BAN SILQ tool reported in the literature are high. Internal consistency reported as Cronbach's alpha is 0.99, and subscales are rated highly as well. Validity reported in the literature is content validity and was established by a panel of 2 nurse midwives, 1 maternal child nurse educator, and 2 labor and delivery nurses. The Labor Support Questionnaire will be used to measure intrapartum nurses' perception and knowledge of labor support provided during labor. The aim of this tool is to help us identify changes in nurses' attitudes, knowledge, and to identify barriers to our intervention. Here's an example of the Labor Support Questionnaire Part 1, Part 2, and Part 3. Reliability and validity reported in the literature for the LSQ tool are high as well. Internal consistency is reported as Cronbach's alpha of 0.92 and 0.86 for Part 1 and 2 respectively, and is not reported for Part 3. There's also relatively high internal consistency for the subscales. Validity reported in the literature is a content validity index of 0.94. The California Maternal Quality Care Collaborative's Maternal Data Center allows hospitals to track monthly, quarterly, and annual trends in C-section rates. We will use this tool to measure cesarean section rates in our identified population. Some characteristics of our setting include that it's a specialized labor and delivery hospital in urban San Diego County and is not for profit. Staffing includes RNs, MDs, DOs. There's a doula program at an additional cost, and there are no certified nurse midwives. In 2014, there were approximately 9,600 births, and the average age range is from 30 to 39. It's primarily white, non-Hispanic, and English-speaking, and insurances accepted are Medi-Cal and private insurance. Our sample size was calculated to provide a level of significance of alpha of 0.05 and a power of 0.80. There are 2 samples in our study. The first sample is to calculate cesarean section rate, in which we'll use 384 low-risk deliveries over a 2-year period. The second sample is a nurse, woman, or patient dyad, in which we'll recruit 299 nurse-patient dyads over 13 months, 1 month prior and 12 months after intervention. Nurses may participate in more than 1 survey. The data collection process is as follows. Trained study nurses will obtain informed consent from nurse-patient dyads upon admission to L&D. Questionnaire packets will be provided to a nurse-patient dyad in the immediate postpartum period, consisting of the LSQ questionnaire for nurses, the BAN SILQ questionnaire for patients, and demographic surveys. Data for C-section rates will be entered into the MDC online tool monthly by study nurses. Confidentiality will be maintained. Data coding and scoring will be performed according to the original author's recommendations. Each question will be scored based on the value assigned on the Likert scale, and then the total score will be added up. The mean score will be evaluated across the study to determine differences. The same will be done for the Bryanton adaptation of the Nursing Support and Labor Questionnaire. The main sources of bias for our study include sampling bias resulting from a non-probability convenience sample. Generalizability will be limited by the sampling method and exclusion criteria. Additionally, given the subjective nature of the questionnaires, self-report bias may be present in the results of our secondary outcomes. Also, inconsistencies in the applied intervention may pose a threat to internal validity. To oppose this threat, nursing leadership will complete bi-monthly evaluations of intrapartum nurses' application of the intervention. To ensure ethical practice, all patients and nurses will sign informed consent with risks and benefits clearly outlined. Additionally, Utmost confidentiality and data protection will be maintained for our study. These represent the primary ethical considerations from our study.